Today, our topic is prognosis in spine trauma. And the primary authors are Dr. Fan Jiang, myself, and Professor Michael Failings. We are associated with Toronto Western Hospital. And personally, I'm from Jurong Health Campus, National University Health System, Singapore. I was an ex-fellow of Toronto Western Hospital. And our Dr. Fan Jiang is a clinical associate in Toronto Western Hospital. And Professor Failings needs no introduction. He's a professor of neurosurgery, vice chair research, Department of Surgery, and director of University of Toronto Neuroscience Program. He's a staff of Toronto Western Hospital. Our key concepts in prognosis of spine trauma is that in our aging population, currently low energy osteoporosis related injuries have surpassed the high energy trauma as the #1 cause of spinal fractures. Patients sustaining traumatic spinal cord injury are predisposed to a higher rate of adverse events and early mortality. The low energy osteoporotic related fractures are closely associated with spinal cord injuries numbers. As we have advanced in our prevention of high energy trauma in both the work as well as road traffic accident related injuries, such injuries are getting lower in terms of incidence, and hence the key concepts are that we have to focus on both the low energy as well as the high energy trauma population in terms of care in spinal cord injuries. Spinal trauma is a devastating injury with the potential for severe consequences impacting the morbidity and mortality of the patient. Acute injuries to spinal cord, conus medullaris, cauda equina, or nerve roots can result in temporary or permanent neurological impairment of varying degrees. Fractures involving the anterior and posterior column of the vertebral body, as well as the spinal segment, can be further complicated by instability, progressive deformity, pseudoarthrosis, chronic pain, or delay in neurological symptoms secondary to spinal stenosis. Cervical trauma patients have more incapacitating neurological injuries than thoracolumbar trauma, with a trend of, however, better neurological recovery. Less severe spinal cord injury often presents with better neurological recovery. Patients sustaining complete spinal cord injury have the worst long-term neurological outcomes. It is challenging, however, to accurately determine the mortality rate in patients sustaining spinal trauma given the heterogeneity in the patient's populations and changing demographics over the decades. While the overall mortality rate in patients' population is in the average of 4.4 to 16.7%, the rate is significantly higher in elderly patients, ranging from 23 to 38%. The predisposing factors for mortality and early death in spinal trauma is advanced age, as we mentioned, multiple medical comorbidities, high injury severity score, typically more than or equal to 15, abnormal coagulation profile, hemodynamic instability, and presence of traumatic brain injury and neurological deficits. The initial injury severity has been shown by numerous studies as one of the significant determinants of neurological recovery. A recent meta-analysis reported that for individuals sustaining AIS or Franco-A or complete spinal cord injury, the expectations for recovery are abysmally low at only about 19.3%, experiencing more than or equal to 1 grade improvement, and 9.2% with a more than or equal to 2 grade improvement. Now, none of the patients with a complete spinal cord injury typically has full recovery in one of the recent meta-analyses. Cervical trauma in particular and its close relationship with critical anatomical structures is of concern. The potential association with life-threatening cerebrovascular events and irreversible damage to neurological elements can be leading to increased mortality and morbidity. And there's an increasing annual number of cases of cervical injuries. Advancement and understanding of neurological care medicine, critical care medicine in spinal cord injury patients has lowered the mortality rate of high cervical lesions, and numbers of patients discharged with ventilators has increased threefold. Injuries to craniocervical junction are often missed with associated high mortality and instability. High clinical suspicion should be required, and appropriate imaging is needed to diagnose fractures in the atlas, axis, and craniocervical junction. Atlas fractures are commonly associated with other injuries, including odontoid fractures, which is reportedly to be found in 40% of the cases. Interestingly, cranial nerve injuries have been previously reported in cases of atlas fracture, and it's often missed if not examined properly. Type 2 odontoid fracture in particular have high rates of non-union when managed non-operatively. We need to consider the patient's age, fracture characteristic before the treatment decisions are made. In elderly especially, halo vest management has been associated with high morbidity and mortality. The risk and benefit ratio need to be weighed prior to its utilization in the geriatric populations. Cervical trauma patients had more incapacitating neurological injuries than thoracolumbar trauma, with a trend, however, for better neurological recovery. In thoracolumbar trauma, however, the related spinal cord injury occurs in about 30% of cases, of which 80% arise in the thoracolumbar junction of T10 to L2. Given the higher energy trauma in thoracolumbar fractures or injuries, thoracolumbar injuries tend to have more associated visceral organ injuries, in addition to the risk of damage to neurological elements. Due to the anatomical vascular watershed region in the thoracolumbar junction, healing and recovery of injured spinal cord could be hindered by poor blood supply. Thoracic spinal cord injury is also associated with the highest rate of complete injury and the lowest rate of recovery. Lumbar spinal cord injury demonstrated the most favorable prognosis, while recuperation from cervical and thoracolumbar injuries falls in the intermediate zone. Recent studies suggest that we should perform surgical decompression and stabilization if needed within 24 hours of injuries in patients presented with traumatic spinal cord injuries. Understanding of the local hospital conditions, as well as how is the comorbidities and stabilization of the patient's condition, is important for expediting the decompression and fixation surgery. In terms of stability, in order for a fracture to occur in spinal column, large external forces must overcome the inherent biochemical stability by the bony anatomy and the disco-ligamentous complex. Numerous injury patterns requiring various degrees of treatment and intervention and standardization of management is needed to ensure optimization of outcome and quality of care. Hence, classification assists in the clarity of description and provides guidance on the management of prognosis of these patients. Over the years, Dennis McCormick has separately described the three-column theory as well as the load-sharing classifications. Subsequently, TLIX or SLIX score focus on the multifactorial consideration of morphology of the fracture integrity of the posterior ligamentous complex and the neurological status of the patient. Recently, AO's Spine Knowledge Forum also introduced a classification system and constantly modifying and upgrading the classification system, combining the consideration of the above-mentioned classifications. Other specific considerations, such as osteoporosis, given the weak bony structures in patients with osteoporosis. Vertebral fracture can occur even with low energy impact. Untreated osteoporosis can lead to additional vertebral fractures, spinal deformity with fixed malalignment, long bone fractures, and increasing the risk of morbidity and mortality. The management of patients with osteoporosis vertebral fracture should not be limited to acute injury only. A multidisciplinary approach for surveillance and prevention, as well as treatment of the underlying osteoporosis, is very important. Ankylosis of the spine presents in another group of patients with challenging medical conditions that leads to differences in prognosis in spine trauma. Ankylosing sponge and disseminated in idiopathic skeletal hyperostosis are both considerations that can bring biomechanical changes to the properties of bone and soft tissues, which leads to stiffening of the spine. And prognosis in this group is typically worse than normal individuals in setting of trauma because of the long lever arm of the ankylosed spine for a force to act upon, resulting in higher risk of dislocation and neurological deficits. Further neurological damage can also occur during the inappropriate immobilization and patient transfer. Overall mortality rate as well as complications are higher in this group of patients. Regardless of surgical or non-surgical management, the complication rate can be reported between 32 to 51% in these patients in DISH and AS respectively. The poorer prognosis and higher rate of complications means we need to be higher clinical suspicion is needed in this group of patients. AS patients often require more care. They have maybe presence of chronic pain, which is indistinguishable with the fracture pain. And pre-existing back pain can be mistaken to be the cause of the current fracture pain. Hence, there's an often delay in the period of diagnosis, and sudden neurological deficit can occur. This phenomenon is commonly known as the fatal pause. All patients with diagnosis of AS and DISH presenting with aggravation of back pain and minor trauma should undergo a CT of entire spine to rule out fractures. In conclusion, patients sustaining SCI, spinal cord injury, represent a vulnerable group requiring high level of clinical vigilance, aggressive surveillance, and prompt management of arising medical issue during the post-injury period. Clinical expertise and appropriate training in spinal trauma are required for the treatment and care of these high-risk individuals. In the author's opinion, the management should take on a multidisciplinary approach to achieve the most optimal outcome.